Welcome, everyone. Thanks for joining us this morning. My name is Margareta Brandt. I'm the Assistant Deputy Director for Health System Performance here at the Office of Healthcare Affordability. Welcome to our 8th meeting of the OHCA Investment and Payment Work Group. And again, if you just joined us recently, feel free to introduce yourself in the chat with your name, title, and organization. And of course, joining me this morning are members of the OHCA team and our partners at Friedman Healthcare. And let's see. So moving on to a few quick updates and our meeting format. So again, here's a reminder of our meeting format and a reminder to feel free to use the chat. We take all of your comments and questions in the chat and either use them after the meeting or try to address them during the meeting if we can. So moving on to our agenda. So starting today, we have a few updates to share with you all. So we have some updates on the primary care timeline, the alternative payment model standards and adoption goals, and some other updates related to our primary care work. And then we'll get into the bulk of the discussion on the revised recommended approach to measuring non-claims primary care spend based on our discussion in January, and then have a discussion on key decisions for setting a benchmark for primary care investment. So we do have a lot to cover today, and we were working hard to get you all the slides in advance, but if we don't get to all of your feedback or questions today, again, feel free to email us or put them in the chat and we will follow up. So moving into our updates. So we wanted to share this timeline again because our timeline for some of our primary care work has changed. So recently, the OHCA Advisory Committee meeting changed from April to March, which kind of rearranges when we are proposing to bring materials to the Advisory Committee for feedback and then back to you all and then eventually to the board. So we are moving a little bit quicker than we had previously anticipated. So that's why you'll see a lot in the materials today, and we'll follow up as needed. So in our March work group, we'll continue to have discussions about setting primary care investment benchmarks. And our goal is to bring an early draft of the primary care definition and investment benchmark to the advisory committee for input in March. And so that's about a month. It's a month earlier than we were previously anticipating. So that's why we've included some options today for primary care investment benchmarks for discussion. And then we'll incorporate the advisory committee's feedback after that early discussion in March and continue to refine that our adoption or our investment benchmark and our definition, and then bring drafts to the board for discussion and public comment in May, leading up to hopefully board approval of the investment benchmark in July. So a little bit of a change in our timeline and why we're moving quickly. So feel free, again, if we don't cover everything today, please feel free to email us and provide additional feedback. So moving on to our update for alternative payment models. So based on the feedback we received from the advisory committee in November, we've made a few minor updates to the alternative payment model standards and implementation guidance. And the clean and redline versions of the standards were shared with you all with the materials for this meeting. So you can see which revisions were made. We don't think any of them were very substantial, but they helped, increase our clarity and about what we're trying to accomplish with the APM standards. So here you'll see we've changed language to be more specific about improving affordability. We've added detail on reducing patients' financial barriers to preventive services, increased our emphasis on supporting a wide range of providers to participate in alternative payment models, and then also added a piece about addressing inequities in patient experience and an emphasis that technical assistance should support providers in performing well on the measures that impact their payment. And our next steps here for the APM standards and the APM adoption goals are to share these with the board at the next week in our board meeting, and also release the APM standards and adoption goal for public comment. And of course, we'll bring feedback, summaries of feedback back to this group before we move forward in our next steps to seek board adoption. So another minor update that we've made to the proposed APM adoption goal is, as you'll remember, in our APM adoption goal, we've included a set of interim milestones to get to the 75% goal by 2034. And based on some feedback we received from the Integrated Healthcare Association on the percent of current Category 4 arrangements, so those capitations or full risk payments that are considered linked to quality, we think HMOs might be able to get to that 75% faster than we had previously proposed. So this is a slight revision, and of course open to more feedback, and we'll present this to the board and can adjust as needed based on that comment and any additional comment that you all have. And I'll keep moving through our next updates, and then we'll pause for any quick questions after this set of updates. So wanted to revisit our proposed recommendation for the definition of primary care that excludes OBGYNs. And again, this is our current definition, open to feedback from the advisory committee and public comment and you all as well. So we are proposing to move forward with including OBGYN services when they are provided by a primary care provider, as we've defined, and at a primary care place of services. So this would mean that OBGYN services that are not provided by a primary care provider would not be included. And all services provided by an OBGYN would be excluded. And this is intends to align with the work group's focus on investing in providers that provide whole person continuous care. And looking kind of at some of the rationale is that OBGYNs may not treat folks with minor acute conditions or more chronic conditions to fully manage their care and have that comprehensive care. And we'll note that some work group members shared that they were unsure about this recommendation or had questions about this recommendation against the requirements of DMHC and other state departments. But others in the work group noted that it would be okay for state laws to promote consumer choice for primary care providers be different than how we define primary care, our primary care spend definition. And again, this is where we are currently and open to additional feedback. And then moving to our next update on primary care claims-based spend and our primary care claims-based spend definition. So previously we had shared that we were considering an approach to try to narrow down the providers who actually provide primary care from our set of providers via taxonomy code. So since our last meeting, we've been working with the Department of Managed Healthcare, DMHC, and others to try to develop a more nuanced approach to identifying primary care providers who practice primary care on a day-to-day basis. So we are proposing this flow chart to use in the claims-based primary care spend definition. And essentially, it's a multi-step process to try to identify a payer's primary care provider using the primary care provider designation in the annual networks reports provided to DMHC. So first, we would start with the payers that payers would start with identifying claims with a primary care taxonomy as identified by our list of primary care providers. And then if the primary care provider is a physician, a nurse practitioner, or a physician assistant, then we would proposing that the payer take the next step of confirming that that provider is a PCP or PCP non-physician medical practitioner as defined in their DMHC annual network report. And if not, then they would essentially be filtered out of the definition. And if yes, they would go through the following steps of the definition. So did they provide a primary care place of service, or did they provide a service in a primary care place of service? And then was it a primary care service? So the example that's come up is that sometimes, internal medicine physicians might have multiple specialties and practice as a specialist in using their secondary specialty. So using this process, that would hope to filter out, is that internal medicine physician practicing as a PCP in the payer's network? And if yes, kind of moves on to the next step. If no, then gets filtered out of the claims-based primary care spend definition. And we're exploring a similar approach and getting more information on whether it is, whether we could use something similar or use a similar designation for other products that are not regulated by DMHC. So we'll keep you updated on how that moves forward and welcome questions or suggestions on this proposed approach. And it looks like, Dan, you have your hand up.
Thanks, Margaretta. And I'm going to put Casey Cameron, who is our Division of Provider Networks Assistant Chief Counsel, on point here for a second. Casey, just want to make sure we're all on the same page. The annual network submission by the health plans to us, where they designate PCPs, does that include OBGYNs in our network reporting?
Yeah, great question, Dan. So it does include OBGYNs when the OBGYN has selected to be a PCP. So under the Health and Safety Code, section 1367.69, basically obstetricians can, or OBGYNs rather, can choose to, they have to be given the option to serve as a PCP. And if they choose to serve as a PCP, then they should be reported as one to us. So we largely depend on how the plan has done its own credentialing of the provider for how they report them to us in the annual network submission.
Thanks, Casey. And just Margaret, I know there were discussions in the last meeting, I think it was, regarding OBGYNs acting as PCPs. And I don't know if I can't recall if we landed. All OBGYNs are considered PCPs, or is it kind of, did we land where Casey explained it, where if the provider chooses to be a PCP, that's how we're aligning this?
It's actually a third option. So
right.
we are proposing at this time that OBGYNs are not included as a primary care provider. But if a other primary care provider, so a family physician, provides OBGYN type services, those preventive OBGYN services, that those would be included. So here, and just, to emphasize, the starting point is the provider defined as a primary care provider by the OHCA taxonomy list, and then moving through the process.
Okay, thank you. I appreciate that.
Yes. And Janice, go ahead.
Thank you, Janice Rocco, on behalf of the California Medical Association. And Margaretta, in your summary, you said that there were some questions about this last time. I would go so far as to say there was some opposition to this last time, coming from me, for one. It's hard for me to wrap my brain around the idea that, as some people said during the last meeting, the statute doesn't matter. And as we're hearing now from DMHC, there are OBGYNs who are identifying themselves as primary care providers because they are, in fact, primary care providers providing primary care. And as we talked about, the statute allows patients to choose an OBGYN as their primary care provider. I feel like the approach that we're talking about here, where OBGYN services provided by an OBGYN are not primary care, but if those same services are provided by a family physician, they are. It doesn't make a ton of sense. And I think that we need to, if we're trying to capture the primary care spend, and we know that for many women, their first and only provider where they seek all of their preventive care, their screenings, their vaccinations is an OBGYN, we're erasing a lot of women from the primary care spend if we go down this path. And it's going to even be hard to track it because if we are working with DMHC and the filings that they receive include some OBGYNs as primary care providers, then they should be included in the spend. So I don't want to erase the healthcare that's provided to a lot of women who choose to seek their care from an OBGYN, their primary care. And the comment about, we're looking for providers who are providing full person continuous care, that's many OBGYNs, full person continuous care. So I just want to go on record. It's not a question, it's a comment.
Thank you, Janice. And I guess to clarify, so is it your understanding, or do other folks have the understanding that OBGYNs are providing more than OBGYN services? Are they providing other types of preventive care or chronic condition care?
They're providing
Yes,
preventive
that's
care.
correct.
Yeah, certainly. But they're providing the things that you're talking about on the list from the last set of slides, the things you listed as primary care, OBGYNs are providing all of those things. So I don't see why. And you even had a slide last time that said OBGYN services, and you listed some of them, and you said those are primary care unless they're provided by an OBGYN. So that to me is nonsensical.
If I can jump in here for a second, I just wanted to clarify that on our annual network submission, we instruct plans to report primary care physicians in accordance with our definition of primary care physician, which is at 28 California Code of Regulations, section 1300.45, subdivision M. And I can just paste that definition into the chat, but it does reference that OBGYNs may be included if they are the physician who has the responsibility for providing initial and primary care to patients, for maintaining the continuity of patient care, or for initiating referral for specialist care. That's kind of the scope of services that the rule envisions a PCP providing.
Thanks, Casey. And I see Beth has her hand raised. Go ahead, Beth.
Thank you. Am I unmuted now? Yes. I think my question goes to how prevalent is this? Can DMHC tell us from our network? I understand what the law is. Health Access was the sponsor of that law. And I understand why we did that. Because for young women in their 20s and 30s, back in the 1990s, often the only care they received was the annual visit to the OBGYN for the pap smear and the once over. So I understand why the law exists. My understanding has been that most OBGYNs do not choose this option. I think it would be helpful to us if it's possible for DMHC to identify this without an undue amount of effort, to know how common it is for OBGYNs to identify as PCPs in the network filings. If we're talking about most OBGYNs doing that, we're in one place. And if we're talking about it happening somewhat uncommonly, then we're in another place. So I just think that sort of baseline information. The other thing I would be very helpful to this discussion, and you notice that I was very careful not to say no OBGYN provides comprehensive services, because I'm sure there are some who do. This is a big state, and there's always some of something. But I just think that matter information would be useful. The second thing I'd say is I want to again go back to our discussion about the current realities versus the vision. And the question I would have for those who represent OBGYNs is the vision that we're moving towards a world in which the OBGYN focuses on those responsibilities, or one in which they provide comprehensive care? And that's, that's a question, and that's part of what this discussion's about.
Thanks, Beth. And I see, Bill, you have your hand raised. Do you want to go?
I did. Thank you, Margaretta. I tend to agree with Casey and Janice's comments, because if we're going to adopt a position that is contrary to statute, we're not going to be, well, we're going to be excluding physicians who are doing this. And this is a matter of patient choice. If a patient chooses under the Knox-Keene Act, the Health and Safety Code, to have their primary care physician or be an OBGYN, that's their choice under law. They have that right under the Knox-Keene Act. And if they do that, I think we should be measuring the performance of those physicians. And also, I think we should be supporting them.
Thanks, Bill. And Dan?
Yeah, just to follow up on Beth's comment, Casey, I'm putting you on the spot again. I believe we can probably pull those numbers regarding OBGYNs who have elected to also perform as a PCP fairly quickly. Casey, is that accurate?
Yeah, that is correct, and I am
Okay.
attempting to pull it up from our database right now. It won't be perfect, but I could get maybe a rough estimate.
Okay.
I'd rather have more accurate than quick at this moment, I think, given how important this discussion is. But thank you, Dan and Casey, for responding so quickly. I think that would just inform OHCA's thinking and all of our thinking.
I think the other thing I need the group to understand too is they are annual network filings. So historically, they've been a snapshot of the plans network on December 31st of the year, submitted to us at the end of March. Our new timely access regulation changed those dates to the snapshot, I believe, is January 15th of the, so it's in the same year, because what we identified in having the snapshot in December was a lot of plan networks change. Physicians come in, groups come in, physicians go out, groups go out the next day. So we're already starting with an inaccurate place. And so we moved that date to January 15th. So it's at least in the same calendar year. But for this year, our network data won't be submitted to us until May. So our most recent data that we'll have available to provide back to this group would be May 1, correct, Casey? And then we'd have to filter through that data as we get it in, make sure all the plans had submitted, get it into different pivot tables and whatnot to provide an accurate, Beth, representation of OBGYNs who are also serving as PCPs.
Yeah, Dan, I appreciate that. And I think on a going forward basis, that'll be very helpful. I think for this discussion and this series of decisions that faces OHCA in the much nearer term, having the baseline of whatever's available would be helpful to inform the discussion.
We'll get to work on that. Thank you.
Thank you, Dan. Thank you, Beth. And yes, Adam, did you want to jump in?
Yeah, just a brief comment. I think this is, the reason for this debate is this is a big gray fuzzy area. I don't necessarily think there's going to be a clear rationale like, oh no, it's obviously this or it's obviously that. I think it's more like a slider. As we move in the direction of including more OBGYNs, we'll capture more of the primary care services that are provided by OBGYNs, which clearly, given that we want to include some of those services in the PCP list, that they do provide those services. But we're also going to start capturing a lot of services potentially that may not necessarily be direct primary care. And we would lose, without going in that other direction by including them, the goal of increasing this coordinated care, and I know there are I've worked with a lot of OB/GYNs who say that they do primary care and that they do coordinated care. But when you think about an organization that does this type of supported coordinated primary care, where they have teams looking at those patients that haven't been seen, are they up to date on their colon cancer screenings and their vaccinations and all the other preventative measures that we think of, transitions of care in and out of hospital for non-OB related issues. OB/GYNs generally, in my experience, I've not seen an OB/GYN that participates in that side of the coordinated care model by one of the organizations that does that type of work. And so that would be diluted by including them. But as I say, it's a slider, and I don't. My concern as I think about these things is our goal is over the course of time to capture the movement and increased spend in prevention and holistic care. And so if we include or don't include OB/GYNs, I don't think there's going to be this huge shift where we're going to overestimate the movement or underestimate the movement. So I can fall on either side and appreciate the approach of seeing which OB/GYNs want to classify themselves as providing primary care. But I think that's really the issue at stake here.
Thank you, Adam. Appreciate that. Any other comments or questions? Janice, did you want to add anything before we?
Just briefly, I'll say, if we're using the chart that's in front of us, we're going to be including some OB/GYNs in terms of when they're providing primary care. The first question, is it a primary care service? Yes. And then, so I don't see a world in which we would be excluding them simply because they're OB/GYNs and when they're providing primary care.
Yeah, thanks for this really rich discussion, everyone. And again, this is not a decision. This is a proposed recommendation. So we can continue to think about this and take this additional round of feedback back to discuss more. So appreciate all of the discussion, and DMHC team, we can follow up with you offline, and maybe we can share out some preliminary data to this group via email to follow up. So really appreciate the discussion, and we'll keep moving in our agenda since we have quite a lot to cover. So I think what I would propose is we have several essentially reiterations of our non-claims or our recommendations for non-claims spending for primary care and how to categorize that. So I would suggest if we could, we'd move through those rather quickly and focus on category 3, which is the shared savings and shared risk section, which we have our proposal that some of our work group members developed, and we've collaborated with them on, and then also category 4 in terms of capitation, since those are two of the a little bit more trickier pieces. So I think, Mary Jo, I'll turn it over to you, but yeah, maybe if we could just move quickly through the first few slides to get to the category 3 shared savings and shared risk payments.
That sounds great, Margareta. So actually, let's go ahead and this is just to remind everyone that our data submitters are payers. They do not know how dollars are spent within a provider delivery system. They are basically reporting to us how they intended to be those dollars to be spent. They do not know exactly how they were spent. I'll say that, by the way, this is true for fee-for-service as well as for non-claims. It's just more pronounced for non-claims. So let's go ahead to the next slide. This is just a recap of the expanded framework. We can just maybe, scroll through these, as I know most folks are familiar with this now. And we can head to just sort of a quick overview of where we landed. I think we talked quite a bit about the challenges of non-claims payments last time, so we can probably skip this slide and move on to the next. And so I'm just going to speak quickly here for a moment and then turn it over to my colleague, Bob Seifert, to talk more about category 3 and 4. So just to give you a quick recap, we have made some refinements to how the primary care portion of these various non-claims payments would be determined. So for categories 1 and 2, these are population health, practice infrastructure, and performance payments. Non-claims payments in these categories would be allocated to primary care when paid to primary care providers and organizations. And then for multi-specialty practices and health systems, payers would identify their primary care programs and allocate only those payments associated with those programs. We do have in the deck some examples of primary care programs. I'm not going to spend too much time on them today. I think they are probably very well known to you, things like care management payments and HEDIS measures where the patient is attributed to a primary care provider. Category 3, we have proposed limiting the portion of the risk settlement payment that is paid to provider organizations that is allowed to be allocated to primary care. So we actually have a revised proposal to share with you today that was developed by some of our investment and payment workgroup members, and eager to talk through that with you. And then for the category 4 payments for primary care capitation, payers would allocate 100% to primary care. That's sort of the easy one. But for capitation, for other capitation payments, particularly those professional capitation payments and global capitation payments, basically data submitters would calculate a fee for service equivalent. We have reviewed this before, but Bob, we can review it again quickly. So with that, I'm going to turn it over to my colleague, Bob Seifert, to walk through sort of a revised approach to the category 3 payments. Margaret, if we want to go to the next slide. And this is just some background. I think we can skip this slide for now. Essentially, the purpose of this slide is really to note that the amount of dollars that are moving through non-claims payments, particularly those non-claims payments that are not capitation, is really small. So incentive payments were generally less than 2% of non-claims payments, or about 0.5% of total cost. So this is incredibly small amounts of dollars. And so while it's important that we capture it correctly, and particularly on the capitation side, since that is a more substantial component of spend, just want to sort of be clear that this is money around the edges and that it's not at this time a significant portion of total spending. All right, with that, Bob, I will turn it over to you.
Great, thank you. So very quickly, this is reiteration from our previous meeting. We've just kind of reorganized this presentation to show what would be definitely included, what would be excluded, and what's kind of in the gray area for category 1 and 2 payments. The gray area in particular are the practice transformation and IT infrastructure payments in category 1. These are often intended to support broader investments in infrastructure. The payments support primary care to some degree, but it's difficult to isolate a portion of them that are specifically for primary care. Other states consider these indirect investments in primary care and limit the portion of the spending that can be counted. So the recommendation here is to limit the portion of these payments, the practice transformation and IT payments that can be allocated to primary care, to just to 1% of total medical expense. That is a precedent that's been set. This is how Delaware and Rhode Island approach this particular type of payment, and we're making the recommendation to do a similar thing here. The rest of what's included in this slide, I think, is review from before. Margareta, should we just move on to category 3, or did you want to? Okay, we will move on now to category 3 and get into revisions from the discussion from the last meeting. First off, just as a reminder, it's very easy to identify risk settlement payments paid to primary care provider organizations as included, and payments for procedure bundles and episodes as excluded. So that's the first 2 columns there. What's challenging here is that most risk settlement payments are made to multi-specialty provider organizations and health systems. So the question is how much of those payments should be allocated to primary care. At our last meeting in January, we presented a recommendation that would limit the amount of risk settlement payments that could be allocated to primary care to the state's primary care investment benchmark, that percentage of total medical expenses that would be that would go to primary care, that benchmark. There was a lot of discussion about that, and as a follow-up, a few of your members, the work group members, got together, came up with a revised approach, which I will quickly go over and then invite a couple of those folks to comment on it on the next slide. This recommendation uses as its basis the portion of total claims-based spending that is for professional services and not for hospital care. So how it would work is that OHCA would calculate this ratio using total healthcare expenditures data, so claims-based professional spend as a proportion of professional plus hospital spend. This would be the limit for allocating category 3 risk settlement payments to primary care. OHCA would then publish this ratio in the total healthcare expenditure data submission guide that the payers are going to use to submit their data. And then each payer would apply the ratio to their total risk settlement payments. And so this would be the maximum amount of category 3 payments that payers could allocate to primary care. That ratio of professional spend as a total proportion of professional plus hospital spend. So let me stop and ask Dr. Solomon and Dr. Howell, who were along with Dr. Grumbach, I believe, developed this recommendation, if they have anything that they would like to add to this discussion.
So I'll jump in. And one comment on what's printed here, and it's between professional and institutional spend. If you simply say hospital, you're missing some other stuff that falls under the institutional side, which is not professional. So just clarification. The concern by the group was that there were several things that we took into consideration. One was by limiting it to the minimum primary care spend, you're in essence capping a percentage at the lowest possible level, and not necessarily recognizing the movement that we're trying to measure, which is towards this comprehensive holistic care to reduce those end level services, which typically end up in an institution. The concern was also around who was involved, and that some of that spend, could it be to a multi-specialty group? Could it be that it somehow is for specialty services? But in general, when there's a reward paid back, there's some sort of incentive payment based on a reduction of expense or improved utilization of services, that is due to the coordination of care, which typically focuses on the primary care team and the team that supports those primary care type of activities, which is the essence of this non-claims based payment. It is, all of the care managers and social workers and other team members that may provide services to help patients navigate the health system and improve outcomes, identify needs, not necessarily submitting claims for them. And that is what we understood what our goal is to really expand, because that results in improved long-term outcomes and reduced spend. And so looking at where those dollars are, that there's no clear divide, but it tends to be more on the professional side, obviously, than the institutional side. And so by putting that split there and saying the cap would be on that percentage of services that are professional as opposed to institutional, would more closely parallel what we're trying to accomplish than just simply the minimum cap on primary care services.
Thank you, Adam. Does anyone have questions or thoughts or reactions to this proposal for allocating a portion of Category 3 shared savings, shared risk arrangements to primary care spend? Yes, Beth, go ahead.
Yeah, my question on this went to we're trying to create something where we can track change over time. And so I think it would be helpful for me if the work group members, or the subcommittee, or whatever I'm supposed to call you all, who spent a lot of time thinking about this, could share a little insight into how they think this would work over time. This is, and give us some insight into that, because Adam articulated a vision of, in the prior discussion, the vision of where we're trying to go, and it's just helpful to understand how this fits as we move from the world we're in to the world we hope to be in.
So I'm not sure if it's directed at me or not, but I'll jump in, and then hopefully others can as well. So if organizations are performing well on what we're projecting, forward as this holistic team-based care, there should be increased shared savings back. The overall outcomes should be better. The patients should be, their health should be maintained, their utilization should improve, and those payments come back. And because a percentage of those payments are recognized as primary care payments, it will show this movement in that direction. And it is a little bit of a flywheel in that more care that's provided in the ambulatory setting, this professional services, if appropriately leveraged, should reduce the institutional spend. In general, the institutional spend is the expensive part. It's the place where it's the end result of potentially inadequate care, although as we know, there's a whole bunch of other stuff that happens. And so you get both an increased percentage of total spend that is attributed to the professional services, and potentially increased shared savings that come back. So more savings that come back, and a higher percentage of those over the course of time would demonstrate a movement towards more of this type of preventative care.
So to say it in a little bit more layman's terms, we would have reduced avoidable emergency room use due to better management of care. We would have, we hope, reduced hospitalization as well due to better management of care. And even, I heard you say something important with respect to OBGYNs, reduced readmissions as well because of coordination of care in the outpatient setting post-hospitalization. And so I think, I just want to call those out because I think we're going to, one of the tasks ahead of us is a discussion of equity and quality measures. And those are all important components there. And I think this ties back to why some of us thought primary care was so much at the heart of the triple aim of lower costs, better outcomes, and improved equity. And so, which I think is a goal everybody on this work group shares. And we're just struggling through how to get from here to there. Thank you.
Great. Thanks, Beth. Thanks, Adam. And so welcome folks, if they have additional thoughts on this proposed approach, to share those in the chat or a follow-up. So I'll propose that we quickly move on to a recap of our proposal for capitation. So Bob, do you want to go through this?
Sure, at 1.5 speed. Because I know we've got a lot still to get through here. Okay, so for category 4 capitation payments, primary care capitation, of course, which is subcategory 4A, would simply be allocated 100% to primary care spend. And then on the flip side, we're saying no facility capitation would count as primary care. What's left from the other from the other capitation categories would reflect fee-for-service equivalent primary care services provided. And I'm going to go through that method in a little in how we're recommending that we do that in more detail on the next 2 slides. Some benefits of this approach is that it's relatively simple to understand. It could promote improvements in encounter data, because this will be based on encounter data. On the other hand, the present gaps in encounter data could mean undercounting primary care, and identifying the correct fee schedule could be difficult, which also creates a potential for gaming the measure. So pros and cons to consider there. On the next slide, here's an example of how this approach would play out for a particular payer that had 4 types of capitation arrangements. The first row shows all of the payers' $100 million in primary care capitation payments allocated to primary care. The bottom row indicates that the payers' facility capitation arrangements do not include any primary care services. And then the middle 2 rows show the result of a calculation using the formula that I'm going to go through in a minute to allocate to primary care, applying a fee-for-service equivalent fee schedule and encounter data for services that would be defined as primary care. $100 million of the payer's $250 million of professional capitation payments, and another $100 million of the $1 billion in global capitation would be considered primary care. And so the bottom line here is, of the $1.85 billion in total category 4 payments across those 4 types of capitation, $300 million, or about 16%, would be considered primary care. So how do we get that? How do we do that allocation based on fee-for-service equivalence? On the next slide, we'll take a look at a diagram of how this would work. In the top box, all capitation payments to primary care providers are included, so that's simple. We sort of put that into the calculation. The box in the center of the slide says that the rest of the primary care payments are the sum of a series of multiplications of quantity times price. The quantity is the number of encounters for a primary care service as defined by the OHCA fee-for-service list. The price is the fee-for-service equivalent fee for that service taken from a fee schedule. The fee schedule would specify fees for each primary care service by payer type, by geographic region, and by year. So each combination of these 4 elements, which are in the oval on the slide, the year, the region, the equivalent fee for the service, and the payer type, is a different, we're calling it a segment. And then the formula, going back to the formula in the center box, says that you take the quantity times the price amount for each of these segments, add them all up, and you have the total category 4 primary care spending for professional behavioral health, global capitation payments, and the payments to integrated comprehensive payment and delivery systems, subcategory 4F. And then note again that we've excluded here facility capitation payments. So that's the approach. It's really arithmetic, but a lot of it, I guess, is the way I would put it. On the next slide, we do a quick, brief comparison here of approaches to determining primary care non-claim spend. This slide is comparing the OHCA recommended approach with the Integrated Healthcare Association and with 3 other states that measure non-claims primary care spending: Colorado, Massachusetts, and Oregon. First of all of the approaches use the same primary care definition to define both claims and non-claims spend. Colorado, Massachusetts, and Oregon do not provide guidance on allocating a portion of capitation to primary care. IHA does, and OHCA is recommending similar guidance to IHA. The IHA and OHCA recommendations diverge. The IHA approach and the OHCA recommendations diverge when it comes to the specifics of the approach. IHA allocates portions of capitation to primary care using a standardized fee schedule and applying it to all encounter data. OHCA is recommending that data submitters use their own fee schedules to capture their best efforts to estimate their spending. For payers that do not have their own fee schedule, OHCA would use or develop a standard fee schedule as part of its technical assistance. OHCA also is not planning to use the scaling methodology that IHA uses. This would not be possible in a decentralized data submission model, which is how OHCA will be collecting the data. Margaretta, back to you.
Thank you, Bob. I know it's a little bit nuanced, a little bit tricky, so we'll want to make sure we have a few minutes for questions before we move on to our benchmark discussion. And I see, Beth, you have your hand raised, so I'll let you jump in first, and then, yeah, folks, feel free to add comments, questions in the chat as well.
Thank you. I like the OHCA proposal, and I think I understand. If we could go ahead to the next slide, please, Bob.
Oh.
Whoever moved the slide.
Yep.
Yeah, I like the variation on the IHA proposal that OHCA has proposed. I understand how IHA would arrive at a standardized fee schedule. I suspect when they started this work, fee schedules were not widely available. But in terms of OHCA and the focus on the responsibility of payers, as well as the larger effort to shift to primary care, I think it's appropriate that so long as we are in a world in which payers vary their fee schedules, which is the world we're in, that it makes sense to rely on the fee schedules. And I also want to acknowledge that payer-specific fee schedules for primary care are not yet publicly available, but I know that for Medicare Advantage, even the entities that rely on global capitation do the conversion to fee schedules in order to meet the Medicare Advantage requirements. So I think it's technically feasible. There's a lot of this we couldn't even have contemplated a decade ago, but I think in the world we're in today, it is my hope that this group will think it's technically feasible. Thanks.
Thank you, Beth. And Joe.
Yeah, thank you so much. Spoke with our actuary team on this, and I think there's a consensus that we actually do not support the current proposal because we don't see a connection between a capitated payment and the fee schedule equivalents. So for example, if we were to price out fee schedule equivalents for all services rendered, it would not actually equal, in all cases anyway, to the negotiated capitation rate. It could come in higher or lower, and there are a number of reasons for that. But we do have an alternative proposal for consideration, and I'll drop the formula in the chat for folks to see. But the basic idea would be to calculate a ratio of primary care as a % professional cost in PPO and use that as a proxy. That's likely, at least from our perspective, to be the most straightforward, although I think we still think we're likely to run into some issues with accuracy on that as well. So I'll drop that formula in the chat for folks to see now.
Can I just ask, and I haven't been involved in the technical discussion, so I'm proceeding for a place of, well, not quite ignorance, but less technical competence on this. I guess I had assumed the fee schedule was the negotiated rate, not the charges. And someone who actually knows what was intended should speak up and clarify if they can, please.
I welcome the payers' health plans to weigh in, but I think our intention is that if a payer has its fee schedule, then that is, its fee for service fee schedule that it would use for non-claims payments or non-capitation payments. So those would be, the payments they would use outside of capitation system. And, we'll defer to the payers if they want to weigh in on, whether those are negotiated or how those are determined. So thanks, Joe, for adding this proposal. Really interesting. And so, okay, I'm looking at it in the chat. But Adam, do you want to weigh in while folks are reading Joe's proposal?
Yeah, I read his proposal a few times and I still don't understand it. Two things. One is hopefully briefer, and I have to rely on others who know better than I do on it, is the global cap that I think, and so this is I need confirmation. I think that when that global cap payment is made, even if the entirety might be negotiated, I think there's still a divide between the institutional portion and the professional portion, that it's not, here's the chunk of money to cover everything. I think it is segregated out. And so that separation should be there already. And then it falls to that first chart where institutional doesn't count, professional does. The other one though is this, and I hate to say something when I don't have an alternative solution, and because otherwise it sounds like just complaining, but I'll just share my concern, and I don't have an answer for it, is that what we're trying to measure is non-claims payments, right? And we're going to use the non-claims payment, we're going to use as a proxy for that, the encounter payments, basically, how much would be billable or is being billed by primary care direct face-to-face services compared to others. And so if our goal is to identify the expansion of the broader coordinated care, that non-claims part really is it, because although we would like to have more patients have a PCP and use their PCP as a primary source for care and to directing that care, a lot of the value that comes from primary care in this kind of model is not derived from those encounters. And because the services provided by primary care physicians tends to be lower level compensation than it is for specialists, and they can't necessarily, moving this direction isn't going to see an expansion in those dollars spent on encounters, because we also have a capacity issue, and the value we're getting really isn't from them sitting there seeing one patient at a time. That what we're actually trying to measure, what we want to capture on those non-claims payments, is not necessarily going to parallel the dollars spent on fee-for-service equivalent primary care charges or encounter services. So my concern is that this is missing what we're actually trying to measure. I wish I had how do I measure those non-claims spent? I don't have anything else to measure it. So anyway, that's my challenge.
Yeah, I think that's exactly the challenge we're all struggling with. And I saw a few other hand raised. Dolores, do you want to jump in from IHA?
Yeah, I'll just say, and I apologize, something's wrong with my camera today. It's not working. When I turn it on, it's just black. So anyway, I think what Blue Shield is proposing is quite similar to the scaling step that IHA does. And I think it is really challenging. There's no perfect way to do it. And, we're always going to be limited by the data that we have, right? And so what's the best approach given that? And so I think one of the things about just applying a fee schedule is it may or may not have anything to do with what like the sum of that may not really have anything to do with how much capitation is paid. And we found that it varied widely when you apply even a standard fee schedule or a plan specific fee schedule. We've done both. It varies widely in terms of how it compares to actual capitation paid, which is why we started doing the scaling step. So at least there is some tie back to what the dollars were that were actually paid. I'm not advocating that necessarily. I do think it's important personally, but I think this is a group effort. And I think that what Blue Shield is proposing is very similar, a little different formula, but like the same concept of trying to really scale the amount to actual capitation.
I think since this is, I mean, obviously this is a very tough kind of question to wrestle with. So I wonder if maybe for the Blue Shield team, Joe, we can connect with you all offline and kind of work for the OHCA team, we can work to better understand the proposed equation, the proposal, and come back to this group with something in March, and maybe even like send out a few slides or something in between that kind of walks through the different proposals for a portion of primary care spend for capitation payments or Category 4 payments. So, and I think I'll pause our kind of questions on Category 4 payments here, so we can move on to our next agenda item, which is also very, a very big agenda item, lots to discuss there as well. So I'll try to move quickly through these next few slides that just provide, again, context for setting a primary care spend benchmark, primary care investment benchmark. And these next few slides essentially recap our statutory requirements related to primary care investment. So these are the, essentially the guidance we took from statute to help develop our proposals and help us think through the recommendation or the options that we've proposed at the end for primary care investment. So I will turn it over to Mary Jo to walk us through the next few slides, and we'll try to just kind of move quickly to get to our options and the kind of the different decisions we could make here related to a benchmark.
Absolutely. All right, so before we review OHCA's draft recommendations on a benchmark, we wanted to share some lessons learned from other states' primary care benchmarking efforts. The first is that sustainable delivery system transformation really requires multi-payer investment to support all populations in access to high-value primary care. However, you'll note that 4 of the 6 states with investment requirements only focus on commercial or Medicaid, not both, and not Medicare Advantage either. So that's a big lesson learned. Another is that it's difficult to reallocate spending to fund primary care in the short term. And if the timeline is too condensed, efforts to increase primary care investment quickly may be inflationary in the short term. The last is that other states' efforts have taught us that increases in total cost of care can hinder benchmark success. As total cost of care increases, achieving primary care benchmarks based on the percent total medical expense becomes more difficult to achieve. All right, let's go ahead to the next slide. So we have 4 key decisions for setting a primary care benchmark. The first is whether to set a single benchmark across all payer types or different benchmarks by payer type. The next is whether to set a single benchmark across age groups or whether to set multiple benchmarks for different age groups, such as adults and pediatrics. The third is whether to set the benchmark based on a percent of total medical expense or a defined per member per month amount. And the last is regarding how to structure the improvement, an absolute target such as 10% or 12%, a relative improvement target like 1% a year for everyone, or some combination. So if we go to the next slide, you'll see how other states address key decisions. This slide is really boring in that it essentially shows that states with primary care spending benchmarks make many of the same decisions. So Connecticut, Delaware, Rhode Island, Oregon, and Colorado all set a single benchmark for all age groups. And they all set their benchmarks as a percent of total medical expense. Connecticut and Delaware set absolute benchmarks with some stair steps or sort of interim goals. Rhode Island started off with a relative improvement goal to get the payers in a place to work towards an absolute improvement goal. Colorado set a relative improvement target of about 1% a year. Maryland, North Carolina, and Oklahoma and Washington are also developing primary care investment targets or benchmarks, and discussions to date in those states suggest that their benchmarks will look similar to those on this slide. All right, let's go ahead to the next slide. So for our first question, whether to set a single benchmark or a set of benchmarks by payer type, it can be helpful to look at some existing data, which we'll do so in a minute. Essentially, what it finds is that primary care spending by payer matters and is different and can vary based on the different needs of the populations and the age mix and the services provided. While setting benchmarks by payer type recognizes those differences, so far all states have decided there's a greater benefit to having a single benchmark across payers to set sort of a consistent, easy to communicate goal. And additionally, many states begin with a relative improvement benchmark, which provides some flexibility to meet different payers where they're at. So let's go ahead to the next slide. This just shows how various payer types in Connecticut performed against the 2021 5% primary care spending target. And you'll see here that primary care investment as a percentage of total medical expense by commercial payers was about half as much as spending by Medicaid payers. Medicare Advantage payers spent even less. And if you think about why that might be, differences in the age mix of these populations is likely one driver, as you'll see just in a couple of slides where we talk about differences by age group. So let's go to the next one. This second decision is whether or not to set a single benchmark or separate benchmarks by age group. As we mentioned earlier, all states that currently have benchmarks have a single benchmark for all ages. So while their separate goals for different age groups may better reflect differences in their care needs, again, a single goal tends to be easier to communicate, and it can be set to reflect the population mix. I want to note that regardless of how OHCA structures its benchmark, it will still be able to monitor and compare investment by age group. All right, so if we go to the next set of slides, we're going to look at how spending for adults and pediatrics varies in California. This next slide here is from OHCA and demonstrates the differences in primary care spend for children and adults among commercial plans from 2019 to 2021. You can also see in the gray bar how the percentage looks when the populations are combined into one to represent the full population. I want to make a note that the two-step process for primary care provider identification that was discussed when we first gathered together today will result in a lower primary care spend than the taxonomy-only approach that was used in the OHCA methodology. So the numbers that OHCA is likely to calculate using that two-step approach likely to be slightly lower than what you're seeing here. If you go to the next slide, we'll show sort of similar data, but for Medi-Cal. So this data also looks at differences by age group. It's about 28% of total medical expense on primary care for kids, while less than half of that, or 11.6% for adults. Again, just sort of a note on methodology. I want to highlight that this Medi-Cal report, which was developed in collaboration with the California Healthcare Foundation, used a different data source and methodology than OHCA is proposing, and we expect the percent investment will be lower than what was used in this methodology. All right, if we go to the next slide, I can talk through the third key decision. And that's whether to set a benchmark based on total medical expense or per member per month amount. The PMPM amount is often more consistent with how payers typically measure healthcare costs, like premiums, for example. It also has less risk of being inflationary if total medical expense increases faster than expected. However, similar to all the other decisions, every state that currently has a benchmark in place uses a % total medical expense. And one of the reasons is that infers or helps communicate that increased spending on primary care should reallocate rather than increase total spending. I also want to note that the statute seems to suggest a preference for using % of total medical expense as a basis for benchmarking. If we go to the next slide, this slide we'll just look at quickly. It essentially shows that whether you use a % total medical expense or you use a per member per month amount, it's highly correlated. So essentially the data seems to suggest that there's minimal differences between recommending a benchmark based on % of spending versus a per member per month amount. The last key decision, which we discuss on slide 36, is whether or not to set a relative or an absolute benchmark or some combination of the two. The nice thing about the relative improvement benchmark is that it meets payers where they're at today, while an absolute improvement benchmark offers a shared vision for the future. The relative improvement benchmark would be consistent with statutory guidance to recognize differences across payers and patient populations, and also acknowledge that care delivery transformation takes some time. Alternatively, an absolute benchmark sets a vision for the future, and it can reflect sort of the potential budget needed to implement primary care capabilities. OHCA's draft recommendation, which we'll review in just a minute, is to set a relative improvement goal for all payers and an absolute statewide benchmark. So you'll see on slide 37, this just shows you some of the variation in primary care spend among commercial provider organizations in California. And you'll see that it ranged from 3% just about to over 15%. Other data on primary care spending for Medi-Cal plans varied, ranging from about 5% to nearly 18%. So this degree of variation among payers further sort of emphasizes that need for a relative improvement benchmark. All right, Margaretta, with that, I'm going to turn it over to you to share a couple of draft recommendation options.
Thanks, Mary Jo. So in kind of thinking about all of these key decisions towards developing a primary care benchmark, primary care investment benchmark, we are proposing 2 options, and we kind of took a step proposing 2 options today based on our faster timeline that we're working towards sharing something with the advisory committee in March. So we really want your feedback on, these proposed options. If you have suggestions for other options, how do we what numbers make sense based on all of the data you've seen so far. So both of these options include a relative improvement benchmark and an absolute benchmark. So our first option today is that we're proposing is that for the relative improvement benchmark, that all payers would need to increase their primary care spending by 0.5 to 1% per year, depending on their current level of investment, up to 15% of total medical expense for primary care by 2034. So this would be a relative improvement benchmark tied with a 15% benchmark across all payers by 2034. So, the potential is that if payers are at 15% or above, currently or within the next few years, that they could opt to maintain their primary care spend at that level if further increases are not aligned with care delivery or affordability goals. And with the note that there is a potential that some payers also may not reach the 15% due to their population composition. So, and then, just to reemphasize that the 15% absolute benchmark is based on just kind of the discussions we've had so far about the need to increase primary care investment, reorganize our healthcare system to be really focused on primary care and prevention. And internationally high-performing healthcare systems spend about 12 to 15% of healthcare spend on primary care. So this proposed 15% tries to kind of take into account the kind of wide variation of spending we're seeing currently across adults and pediatric populations and older adults, and proposes a benchmark that is fairly aspirational, but also, you know, there's a relative improvement path to get us to 15% by 2034. And then our next option, option 2 here, is a proposal to have 2 benchmarks, one for the adult population and one for the pediatric population. So again, here to reach these 2 benchmarks, we're proposing a relative improvement benchmarks along the way, where payers increase spending by 0.5 to 1% per year. And for the absolute improvement benchmark here, we're proposing a 12% absolute benchmark for adults and a 24% absolute benchmark for pediatrics. So this would be 12% of total medical expense to primary care for all adults by 2034 and 24% for all children by 2034. So both options were proposing the relative improvement benchmark and the absolute benchmark to provide that kind of pathway and show that relative improvement is very important as we move towards this absolute goal. I think also for the numbers here, this kind of 12% lower than 15% from the other option to recognize the lower spending in the adult population for primary care, and the 24% is kind of based on some of the ranges we saw previously for pediatric spending and primary care. So with about 10 minutes left, I know it's not a ton of time, but really want folks to weigh in on these options, on these kind of key questions for informing the benchmark. So we'll pause for discussion. And Beth raises quickly, sorry, just in the chat, Beth raised one of the questions we've been wrestling with internally, is whether if we're proposing 2 benchmarks, should we also consider 3 benchmarks? One's for children or pediatrics, one's for adults up to age 64, and then adults over 65 for Medicare. So, you know, there's, you know, option 3 could be 3 benchmarks based on different populations. And so I'll turn it to Catherine. And Catherine, you might be on mute. I think you're. Oh. Can you all hear Catherine?
We still can't hear you, Catherine.
I wonder.
You might have your mic on the wrong setting.
Can you hear me now?
Yes.
Yes. Okay. Thank you. Sorry about that. Before weighing in on the 2 options, just had a question for context on the year 2034. Does that align with other statutes? Does it just sound good because it's 10 years out? Or is there some data that supports how long it will take payers to get to those sort of relative benchmarks? I'm just curious of sort of where that number comes from and how it relates to the other pieces here.
Yeah, so I will let Mary Jo weigh in too, but one proposal is that it aligns with our alternative payment model adoption goals by 2034 as well. So keeping those consistent. But Mary Jo, are there other?
Just one other one. So we find in our work in states that asking payers to increase primary care spending by more than 0.5 to 1 percentage point per year is tough. You know, you're essentially working against an increasing number, right? Which is TME. And so this essentially, for the average-ish payer, gives them sort of a reasonable ramp up with that knowledge in mind.
Got it. So it does align with others, but also really what it takes to make that improvement year over year. Okay, thank you.
Correct.
Beth, go ahead.
Yeah, just it strikes me that, and the Medi-Cal data was helpful on this as well, that certainly people over 65 require primary care as well. In a well-run system, the primary care doc anchors their care, but understandably their use of institutional care and specialist care increases. So, and I also want to continue to reflect on what it is that the state of California has authority over. I mean, we can encourage Medicare and Medicare Advantage, but we don't run it. And so I think, you know, I know the children's groups who we work with closely would want to separate out pediatrics. And I think there's an argument for separating out the, you know, the adult population under age 64 from the adult population over age 65. And so just want to suggest that for consideration. I like the combination of relative improvement and absolute benchmark in keeping with OHCA's approach of saying this is where we want to get to, but it'll take us some time to get there. And so I think that's a nice combination that acknowledges that different organizations are starting with different realities, and that we need to, but that we're progressing, we're trying to progress everyone to the same better place than where we are. Thanks.
Thanks, Beth. Do others have thoughts, reactions to, you know, adult versus pediatric benchmarks, a combined benchmark, the specific numbers in the benchmark? So it looks like
Margaret, it looks like we're getting some good, oh, sorry.
Yeah, I was just going to say, it looks like a few folks are in support of the combination of a relative improvement benchmark and absolute benchmark. Other reactions to a single benchmark versus multiple benchmarks by population? Okay, our folks, I know we had some interest in the, you know, the multiple benchmarks by population. Anyone have an alternative opinion? Okay. Yes, Catherine, yeah, feel free to jump in. And I think you're on mute again.
I don't have a strong opinion. I can see that rationale for both option 1 and 2. I guess I would offer, pulling the thread that Beth introduced, if you're going to do the work of separating it by age group for children and adults, I would add in the 64, 65 and above population for all. I think that makes a lot of sense, exactly for the reasons Beth described. And in addition, it'll give you a little bit more of a window for the Medi-Cal population on the SPD. Which we know from the data Mary Jo just shared has the absolute lowest primary care spend. So again, I could make a case for either, but I would say if you're going to do the work to separate by age, do it by 3, not just by 2. I think that's a better window.
Thanks, that's helpful. And Adam, go ahead.
Just a question for clarification. If we separate out the over 65 group, given that they're in Medicare, I think we have access to the MA information. Would that over 65 group include traditional Medicare as well somehow, or is it really just focused on the MA portion?
I would hope it would include both. I mean, we still have very substantial traditional Medicare. And you're getting data from CMS, aren't you, Margareta?
Yeah, for THC, or sorry, no acronyms, for total healthcare spending, for total spend, we will be working with CMS to get data. And I don't know if anyone from that team or folks want to weigh in, but we can, I think what we're thinking is that the most impact we could have would be in the Medicare Advantage population, based on the commercial payers' participation in Medicare Advantage. But we can look to see what we would be able to get from traditional Medicare.
I would think, given that you have actual claims data, there would be a way. It might take a while, or it might be the HPD that gives you the data. You ought to be able to separate out primary care from, with all the caveats that are running through Adam's mind, as I can see at the moment, to separate out primary care from. Certainly, we can separate out professional services from institutional, and we could probably get at least some kind of fix on primary care on the traditional Medicare side. And it might be one of the things OHCA should, it's not our primary goal, but an incidental benefit of all this work is we should contribute to the national discussion.
Yeah, and I think the part on the traditional Medicare that I just want to make sure we would capture are those non-claims and incentive-based payments outside of the typical fee schedule, because again, I don't know if we go through the Medicare fee-for-service, that we're going to see, even if more care is provided in the this method that we're thinking about, that it's going to result in more primary care encounters and more dollars going to because the fee schedule is the fee schedule for the federal government. And anyway, so it's those additional ACO type and advanced payment model dollars that we would need to be able to track and attribute through Medicare. As far as, I don't feel strongly as far as the overall benchmark, should it just be one global or should it be divided? I think once you open up the box of saying, well, maybe we should split it, given that, clearly pediatrics is very different than seniors, right? And even in that adult, the 18 to 64 population, the Medi-Cal portion and the non-Medi-Cal portion quite different as well. So suddenly then it's like, well, if you're going to do it, then you should do it. And those four categories are quite different, and maybe we should focus. And at the same time, it just ramps up the complexity. And do we get the value we really want for adding that complexity? Or if you allow it to be global, overall, if it's moving in the right direction, at some point, it's all going to be addressed. And so keep things simple and just do one benchmark across the board. I'm generally open. And then my last comment is, it's a little hard for me I think we should have a target and then relative improvement. I think that's clearly appropriate. What that ultimate target is, though, is difficult if our methodology of measuring is different than others, and we're using others' experience to set that target. And we don't know what our percentage is now because we've just defined it. I don't know if we're hampering ourselves or overestimating ourselves once we come to that number. So I'm a little scared of setting those specific benchmarks, but that's just my feedback.
Yeah, that's a tough challenge, since we're aiming to seek board adoption or board approval of a benchmark before we would have data submissions to analyze. But we also could revisit this benchmark after a few years of data. So we could come back to see how the benchmark, how folks are progressing towards a benchmark, and have we set it appropriately or not. So there's an option to revisit the benchmark. So I know we are a few minutes over time, so really appreciate all of the discussion today, all of the feedback and comments. We, we'll kind of try to synthesize this work. We'll follow up with folks, Joe in the Blue Shield team, especially on the capitation piece. And we will share some information with you before we bring it to the March advisory committee meeting for their discussion and feedback. So thank you all for the great discussion today, and thanks for your input as we try to move a little bit faster than we had previously planned. So thank you all. Have a great day.
Thanks, Margareta. Thank you.